Welcome. Well, today's webinar takes on a slightly different focus. The topic is particularly important to those who have not yet actually been diagnosed with thyroid cancer. So in our audience today and in the future, when others access this webinar at their own convenience on the ThyCa website, there are likely to be people who are not familiar with ThyCa. So to you, welcome. So now's a good time to remind you all that this webinar will be available on the ThyCa.org website. Be sure to visit it. For those of you who are ThyCa.org users, it's not too early to start making plans for the annual meeting. This year's meeting, the 16th annual, will be held on September 27th through the 29th in the Philadelphia area. Be sure to look for details and make your plans. If the annual conference doesn't work for you, consider one of the regional conferences or perhaps a local group event. All of this information can be found on the ThyCa.org website. So today's topic addresses the workup of thyroid nodules. Fine needle biopsies don't always provide us with the information that your doctor needs, and thousands of people each year undergo thyroid surgery only to find out that they don't have thyroid cancer after all. Fortunately, research has provided us with a reliable testing method to help eliminate some of those needless surgeries. Our presenter today, Dr. Erik Alexander, is an endocrinologist from the Dana Farber Cancer Institute and Brigham and Women's Hospital in Boston. He was not only helped with the developing and especially the testing of gathering enough information to determine that this new test is reliable enough to play a role in clinical practice. But before I turn the microphone over to him, I want to remind you all that if you haven't already given us your questions, please do so, and Dr. Alexander will address them at the end. So without any further ado, it is my pleasure to now present Dr. Alexander. Dr. Alexander, welcome, and thank you for being with us today.
Thank you, Jan, and thank you to everyone here who has signed in and for those who will be listening to the recording here at a later time. So it's my pleasure for the next 15 to 20 minutes to really review some of the exciting data that has recently come online in terms of the Afirma gene expression classifier and how we see this medically and how it may be of use to patients. We'll also stop for some questions then at the end. So my disclosures, as you see here, I've been involved with many of the trials that have helped to investigate these molecular markers. And what I'd like to cover here for the next 15 to 20 minutes is this. Why is it that we evaluate a thyroid nodule? How do we evaluate a thyroid nodule? And what are some of the drawbacks to the traditional diagnostic approach? And how has the Afirma gene expression classifier helped to address some of these drawbacks? And where does it play in the current standard? And often the best way to start here is to discuss kind of a typical patient, which may apply, this story may apply itself to your story listening in. A 48-year-old female is found to have a thyroid mass, incidentally during a CAT scan performed for another reason. And the mass is actually asymptomatic. She reports no prior thyroid illnesses. And the patient actually is in very good health, appears clinically euthyroid, but on exam, a 2.5 centimeter left-sided nodule is felt. And it moves when the patient swallows, and there's no lymphadenopathy, a very typical exam. And the marker of her thyroid function, which is called TSH, is normal. That's 1.9. She's not on any medication for the thyroid. And as often happens in these settings, a fine needle aspiration is recommended. The nodule may look something like this. This patient with a very thin neck, but nonetheless a large nodule you see on the patient's left-hand side. And as we start this discussion for this patient, the first obvious question is, well, why do we evaluate a nodule in the thyroid? And the quick answer here is that there is a risk that nodule could be cancerous. And we certainly want to both detect it and then treat it so that the cancer does not cause downstream harm. This leads to the obvious subsequent question, which is, well, what proportion of thyroid nodules are indeed cancerous? And I begin to show this here on this graph, that if you look here on the y-axis, this shows the general proportion of cancerous in a series of nodules that have been collected. And most of the data that is available to us comes from simply a single hospital or a single institution. And there have been many that have been published over the course of several decades. And I simply show the date of publication here on the x-axis. What you'll notice here is in the blue now, beginning in the mid-90s, the actual finding, the answer to the question, what proportion of a given group of nodules will prove cancerous, seems to have gone up just a bit. And that does correspond to when ultrasound was being used to a greater degree to detect and to biopsy these nodules. But you'll see that all of these studies roughly come in line, that we generally will answer the question by saying that the proportion of cancerous nodules may have increased a little bit over the last several decades, but in general, about a 8 to 15% risk exists in any nodule over 1 centimeter that it may be cancerous. So that is why we evaluate a nodule. And how do we evaluate a nodule? Well, this traditional approach here has been in place now for about 30 to 40 years. And again, we find for most patients that nodules become clinically relevant when they're larger than 1 to 1.5 centimeters. At times, we do have to aspirate nodules smaller than that, but for most patients, it's when they're larger than this cutoff that we move to next steps. And almost all patients will have an ultrasound and then have a check of their thyroid function, which is a serum, a check of TSH. And we're hoping that at times we find the TSH to be low because that could signal that the nodule is producing hormone, which is what you see here on the left portion of the slide. That would lead us to do a thyroid scan, and if the nodule is functional, that is not a cancerous process, and that is treated simply for the hormonal aberration. But that's a rare finding, and most of the time the TSH is normal or elevated, and we recommend patients receive a fine needle aspiration or a biopsy. Well, coming back to the patient, this is often what can happen. So as we went and discussed about the incidental nodule, the patient was sent for a fine needle aspiration, and this was done with ultrasound guidance as we typically recommend. And the actual tissue, when looked under the microscope, which is called fine needle aspiration cytology, returns here showing this description. And we won't get too wrapped up here in the medical terminology, but it will be labeled here as suspicious for a follicular neoplasm, and we'll talk about what that means by moving here to the next slide. When one looks at large populations of nodules that have been evaluated, if I took 1,000 patients from my institution, and I asked the question, how do they typically fall out? What are the proportions that have certain diagnoses? This is what we typically will find. We like to classify those samples by a special system called the Bethesda classification. This is the terminology that we use so that we have a common language and we can convey a meaning to each other within the medical community. And what you'll notice here is that in any given population, about 2/3 of the group will have a benign result. It will be no malignant cells, and that's very accurate, very good. You'll notice that about 5% on average will be cancerous or malignant, usually for papillary carcinoma, a type of thyroid carcinoma. But I draw your attention to that 20 to 25% that is in yellow here labeled indeterminate, because that is really the problem we have faced. You'll notice that there are 3 categories underneath, and those are the specific Bethesda terms that we often will see listed out. And the one that we saw for our patient was the middle one there, suspicious for a follicular neoplasm. What this means here is that there is something abnormal with the cytology. They cannot tell for sure if this is benign or cancerous, and therefore it remains cytologically indeterminate. This means that the risk of cancer is not completely zero, but also we don't want to imply for sure it is cancer, and this has been a problem area. Because the risk of cancer, however, still exists, it is usually patients within this yellow box that are referred for surgery. Because the risk of cancer was still present, the only way to know for sure was to remove it surgically and look at the whole sample under the microscope. And so you may say, well, that's been the standard for 30 to 40 years. What is the problem? And the problem really has been this, that when you actually then correlate the actual biopsy cytology, what you see on the left, to kind of the final answer here on the right, which is how many truly have cancer when the gland is removed on histopathology. We look at these different terms that we went through, in particular the bottom 3 terms here, which are indeterminate, suspicious for papillary carcinoma, suggestive of a follicular neoplasm, or atypical of an undetermined significance. you will see here that these have a decreasing risk of being cancerous, 70%, 27%, 24%. What this means is that we're doing the surgery to detect those malignancies, but unfortunately we're also sending many patients to surgery who do not have malignancy. In fact, when you take all comers who we have to send to surgery because of an abnormal biopsy, it turns out that most of them do not have cancer. They have benign disease, so that would be unnecessary surgery. So just going back to one of our earlier slides, this is the traditional approach as I showed you, but I'll put one more arrow and now some new text to the upper right, which is that we do this fine needle aspiration in most individuals, and we hope that the FNA cytology comes back benign. This would allow us to be conservative and follow a patient without further intervention. However, if it's abnormal, even if it's just indeterminate, we usually are heading towards considering surgical removal. And just one or two slides here that obviously no one wants surgery for the time away, the morbidity, the cost, but there are also some complications, and this is one of the other medical reasons that we certainly want to avoid surgery unless it's needed. Most importantly, you'll see kind of the second box down, that we worry about two complications, hypocalcemia, which is due to damage of the parathyroid glands, and some nerve damage, which can interfere with voice function, as well as rebleeding, infection. If you put this all together, it's likely the risk here of having some long-term complication is somewhere between 2 and 10%, and that is not trivial. We also know that the more thyroid surgery you do, the better your complication rates, the lower your rates. You'll note here on the slide to the left that this study that looked at how many thyroidectomies a surgeon did per year, whether it was 1 to 9, 10 to 29, 30 to 100, etc. If you look then right below at the complication rate, you will see that this is nearly 50% lower when people are doing over 100 cases. And what's unfortunate and difficult is that we're not all able to access surgeons who are doing this high of a volume simply because of where we live in the country. And so we do want to kind of optimize surgery for when it's needed and for who it's needed. And we also want to avoid the high cost if we can. So the goal here is to reduce unnecessary surgery. So this has led to this broad question, can we do better as of 2012? And fundamentally what this really is asking is, can we better assess the risk preoperatively and as to whether that nodule is cancerous? Can we better assess the risk that any thyroid cancer could pose to an affected patient? Or can we more accurately define the risk of potential unnecessary intervention? This is what we as physicians try and do on an individual and on a daily basis. Now, I do want to mention that while we're going to talk here about a molecular test upcoming, clinicians have been able to assess risk to a better degree over the last many years than they ever had before. For example, if you take this graph here, and we had mentioned in yellow the baseline cancer risk here of roughly 8 to 15% that you see, there are a few clinical variables, young age, male sex, certain high-risk clinical findings that will increase that risk a little bit. As I mentioned to you, certain FNA cytology, or the way that the tissue looks under the microscope, will also provide a graded risk assessment. And we use radiology as well. Things like ultrasound, nuclear scans, even PET scans can adjust the risk of what a nodule, whether the nodule is cancerous or not. I bring this up because we have done better, and I want that to be very clear. We're still imperfect, but we have been moving forward. This looks over the course of time on the x-axis from 1980 forward at really the fundamental variable that we would want to be perfect, which is surgical yield. How many patients are we as physicians diagnosing with cancer compared to how many we are sending to surgery? So we would like this to be perfectly 100%. But what you'll notice here with the finding on the y-axis is that several seminal studies are showing that we're improving, but we're only up about 50%. We have a ways to go. So to summarize really the current approach and the need here before we move on then to the test, the diagnostic process at the present time is highly sensitive and specific because it's identifying about 2/3 or 70% of nodules as benign, where we recommend a conservative approach. and it is detecting about 97%, almost all of the thyroid cancer, so that's good. But it's very much imperfect for these reasons. Those high numbers, that sensitivity specificity, is only achieved when multiple steps are combined. And the most important diagnostic test, which is that biopsy called fine needle aspiration cytology, is not specific. And what this is leading to is a lot of unnecessary surgery and unnecessary morbidity and cost. So this is the natural lead-in then to what has come online now in the last year or two, and the available data really in the last 5 months, which is how we're combining this cytology, the traditional biopsy, with molecular analysis now as well. And in particular here, the Afirma gene expression classifier, a new test looking at a set of molecules in the cells as opposed to just how they look under the microscope, and hoping that this can improve our ability to send the appropriate patients to surgery and to reduce the unnecessary surgery. I will say this also is the only marker out there currently in the thyroid diagnostic field at present with a large-scale prospective validation study, and that's what was published here in the New England Journal of Medicine approximately 5 to 6 months ago. And so let me talk about these data to give you some backdrop. The concept to this test was, again, taking the need that we just discussed. Could you take the human genome, all of the molecular markers in your genes, and try and then apply a mathematical calculation to produce a test here that had a very high negative predictive value? What that means is if the test comes back benign or negative, it's very predictive that indeed there's no cancer in the nodule, even if the cytology was indeterminate. And so this began with a concept that we looked at all of the 22,000 genes that are expressed. We began to narrow it down through development. And ultimately, the test itself looks at 167 genes or markers based off that tissue that we get at fine needle aspiration that is sent off for analysis. And I do want to emphasize here the study design, and though this often is something that is a little bit above and beyond what patients will typically ask, it is vitally important to us as physicians that we have data here that we really believe is very translatable into the care of individual patients because it was done in a very large-scale prospective fashion. So this took us about 2 years, but involved about 49 different clinical sites that were enrolling patients. And it was one done in a double-blinded fashion so that the patients and the physicians were unaware of the molecular results, and the lab itself was blind to the surgical pathology. So this is exactly kind of the best way to do a study. And here was the top line, or the main result, that when we enrolled patients, again, who had these indeterminate cytologic nodules, those ones that were suspicious or atypical, that when we looked at a good group here after enrolling 4,000 patients, and we ultimately ended up with 265 here who we could evaluate with indeterminate cytology, that the classifier, the Afirma gene expression classifier, was able to identify the vast majority that were called benign as indeed being truly benign. What this really tells us here is that the negative predictive value for all cytologically indeterminates were 93%. Let me try and explain this a little bit more simplistic. This looks at, on the left here in yellow, at the FNA cytology diagnosis. These are these 3 indeterminate categories that I mentioned. The top one is the atypical of undetermined significance, or sometimes called follicular lesion of undetermined significance group. And so when we applied the analysis here of the Afirma test to that subgroup, and I want you to focus here on what's in blue, the negative predictive value of having a benign Afirma result. Despite an abnormal cytology initially, the negative predictive value is 95%. That means there's a 95% chance that indeed a benign result really means that there's no cancer. Now that is very similar in terms of numbers to the actual negative predictive value of a benign actual cytology, the actual tissue looked under the microscope. So we would consider that something that can likely impact care and change management quite significantly. So similarly, if one had an indeterminate nodule that was a follicular neoplasm, another cytologically indeterminate category, the negative predictive value 94%. Even for suspicious for malignancy, it was 85%. And currently, the test right now is not recommended for patients routinely who have an FNA cytology diagnosis that is suspicious for malignancy per the Bethesda classification. And that's simply because that NPV is still not quite high enough to fully recommend avoiding surgery. In some unique cases, it certainly may be, but that would be an individual decision. So to summarize, this Afirma gene expression classifier is hypothesized, designed, and developed differently. It was really designed to maximize that negative predictive value of looking at these set of molecules when we applied it to the cytologically indeterminate nodule. You'll notice there's a large number of markers. There were 162 genes that we look at for every test, and I think this is critical because there are so many different types of thyroid lesions, both cancer and benign, not just one. And I do want to emphasize this is the only prospective large-scale and double-blinded validation, the one we published in the New England Journal. I think that really is very important for me as a physician and for you as a patient to see if this can be translated effectively into the care of your nodule. So I asked the question here, can we do better as of this year? And the answer is we certainly are doing better. And I want you as patients to realize your physician is always going to be taking in all different variables, the demographics of who you are, the ultrasound findings, the cytology, and now the molecular risk assessment, and putting this together to give you the best recommendation. But I do think this is increasingly becoming the new standard, that what was going on here for 30 or 40 years, which was simply an ultrasound and checking serum TSH, and then moving us towards fine needle aspiration has evolved very quickly to really look and say, well, if the FNA cytology is benign, then we stop, and that's an excellent, excellent finding. But if it is abnormal or suspicious or any of the other categories that imply a possible malignancy risk, then using the Afirma gene expression classifier is proving to be highly valuable. The reason is that if that gene expression classifier, if the Afirma is benign, it is reasonable to consider a no intervention, no surgery, because of that low negative predictive value. So with my appreciation here for listening in, the conclusions here, and hopefully some background that I've been able to provide for you, the initial diagnostic approach to any thyroid nodule over 1 centimeter still should remain an ultrasound-guided fine needle aspiration and typical visual cytologic interpretation. So that has not been changed, and the Afirma test should not take the place of that. That still has to occur. But as I mentioned, unfortunately, 20 to 25% of nodules will have this abnormal cytology, where malignancy cannot be excluded and therefore surgery is often recommended. But that's suboptimal because surgery is unnecessary in about half of patients, and it does carry risk, morbidity, and cost. And this is where molecular analysis of the specimen is addressing this problem. And the Afirma gene expression classifier analysis should be considered for all cytologically indeterminate nodules, especially those that carry that classification atypical of an undetermined significance and suspicious for a follicular neoplasm. And it is designed differently. It was hypothesized and trained and validated with this concept of reducing unnecessary surgery. I would also just close then by saying, as we translate this into the clinic, the results from large-scale multi-center investigations that use a lot of very high-quality study metrics like blinded histopathologic assessment are really critical. And this is really the first one thus far in this field. And so I think it puts a lot of extra weight behind the actual Afirma classifier. With that, I'll end, and I'd be more than happy to turn this over to some questions.
At this time, we would like to take any questions you might have for us today. To ask a question via the web, click the Q&A button on the lower left-hand corner of your screen, type your question in the open area, and click Send to Submit.
So I do have several questions here. I'll just go through them one at a time here. One question was describing a series of events that they had been conveyed to them from their endocrinologist, which was that if you have a nodule and you have a indeterminate initial fine needle aspiration, such as a follicular neoplasm again, if you have that performed a second time, even if it comes back normal, does that or does that not invalidate the first finding on fine needle aspiration? And how does this all work with using the Afirma test in this scenario? That's a very good question. And a little bit here is at times we try and make guidelines for all of us in the country that are somewhat structured and linear, whereas with certain patients there are several options. What I would say is there has been some data published that does suggest that if you have especially a very low risk indeterminate lesion, which would be classified typically AUS, that a repeat biopsy can come back cytologically benign the second time, and at times that can be considered very reassuring of indeed a benign process. There are some individuals when we look at all of the variables that we think they may not need any further testing after that. However, remember that your clinician will be looking at all the variables, and exactly as was stated, if you had an indeterminate cytology the first time, and then even if it came back normal the second time, but I was worried about the way the nodule looked on ultrasound or the growth pattern or some clinical symptoms that you were having, that would lead me to say, you know what, I still am concerned by the majority of the data, and so I would like to either repeat the biopsy, consider the Afirma test, or in rare circumstances, we even move forward with surgery. So I do want to impress upon the questioner here that we want to make sure we use all of the clinical variables. A second question came in here. Does the Afirma gene expression classifier test determine every specific type of thyroid cancer, such as papillary follicular carcinoma, the variants, medullary carcinoma, anaplastic? The answer here is yes, and a very impressive yes. This study was done, again, in such a wide-ranging, multi-centered way with so many entry and subjects into the study. We were able to enroll such a diverse group of patients and nodules with diverse pathology. So it does accurately seem to be picking up rare malignancies like medullary and anaplastic, and then also has been trained and validated on a large number of follicular carcinomas, peripheral cell carcinomas, and most certainly the most common papillary carcinomas. So I do have confidence in that regard. Next question, if the patient has multiple nodules, does each nodule need to be tested? And the answer here generally is yes. Remember that nodules become clinically relevant when they are larger than 1 centimeter as a general cutoff, roughly 1 to 1.5 centimeters or larger. And we do know from published data that each nodule is independent in its overall risk. Therefore, if there is more than one nodule present that's over that size cutoff, we do want to evaluate each of them. Also, separate question here, is this test ever used after surgery to confirm a benign diagnosis or cancer that may be present? That's another nice question. The answer there is no. This is designed specifically for use with the biopsy, so before the surgery. Our pathologists have many different other techniques, stains, and ability to really determine things, even molecularly, after the thyroid has been removed, and so there is not as much of a need right now in that area. Where the real need is and where the Afirma comes into play is before surgery, and that's where this is designed to be used. And separate question, can this test be used for people who live in rural or remote areas? What are the steps their local physician needs to use? Does the physician need to arrange for the Afirma test in advance of the FNA sample? And the answer here is yes. It is certainly widely available in the United States at present and increasingly being used in multiple different clinics and hospitals. But it is a test that does require unique and separate processing of the biopsy, and it does need to be shipped out in a timely fashion, et cetera. So you do have to plan in advance, and a simple phone call to the clinic or to an endocrinologist, and they can certainly determine if they are able to do it, or if not, refer you to someone hopefully close who can. And along those same lines, question here, is the gene expression classifier analysis available in Canada? And I don't believe it is at the present time, though I would refer this questioner to also look on the VeraCyte website where they may have more information. I simply do not know exact details, so I believe it was first launched just in the United States. And one final question here. Medullary carcinoma is carcinoid or neuroendocrine. This type of tumor is only 50-50. That the hard nature of the tumor will allow collection of cells, even in the hands of a center of excellence practitioner. How does this approach help? I'm having a little trouble understanding the question exactly. I believe it says that it may be hard to obtain an adequate sample or biopsy because of the unique nature of the cellular material. What I can say from this is we have had excellent luck with the Afirma gene expression classifier with detecting almost all medullary carcinomas that have been enrolled in any of the studies or validations. It has such a unique molecular signature that it seems to really pop out very different from anything benign. The importance here is that you do need to get an adequate sample, most certainly, and so that comes down to, as you say, having a practitioner who has performed the biopsies many times before, and at times also perhaps doing a few extra samples to get the best amount of cellular material. I hope that was able to answer that question adequately. And I believe that's our last question, and so I appreciate your time on the call here, and I hope this has been of use to you. I thank you very much